Good day, everyone. My name is Jennifer Butlin. I'm Executive Director of the Commission on Collegiate Nursing Education. Welcome to CCNE's webinar addressing Standard 3 in the 2024 Standards for Accreditation of Baccalaureate and Graduate Nursing Programs. We're thrilled to have so many of you joining us today. We are scheduled for a 90-minute webinar dedicated to Standard 3. And I might add that this is the final webinar in a 4-part series addressing each of the 4 standards in the 2024 Standards for Accreditation of Baccalaureate and Graduate Nursing Programs. We offered Standard 4 webinar was last week in early December. And prior to that, we offered the Standards 1 and 2 webinars. So please come back to the website and go where you've joined this same webinar, and you will find archives of the webinars already posted for Standards 1, 2, and 4. So if you weren't able to join us for those first 3 webinars, please go back and visit the archives, share the opportunity with your colleagues. It's wonderful to have this information recorded at no expense to our communities of interest and available to you as you learn about CCNE accreditation and as you prepare your self-study documents in 2025 or beyond, or a progress report, for example, that might be due to CCNE in the coming months or years. So I'd like to begin by welcoming our 2 wonderful presenters. I am joined by Dr. Ann Hirsch, Professor of Child, Family, and Population Health Nursing in the School of Nursing at the University of Washington. Dr. Hirsch has served as a co-chair of the CCNE Accreditation Review Committee and most recently co-chaired the Standards Committee, resulting in this document, the 2024 Standards for Accreditation. Dr. Hirsch also serves as a team leader for CCNE, has presented at evaluator training sessions, and has experience hosting CCNE on-site evaluations at her home institution. I'd also like to welcome Dr. Susan Rupert, Associate Dean of Graduate Studies at the Cizik School of Nursing at the University of Texas Health Science Center at Houston in Texas. Dr. Rupert is past chair of the CCNE Board of Commissioners, is finishing a term in 2025 on the board representing faculty in nursing programs. She currently serves as a member of the Report Review Committee and has served in many other capacities, along with being a member of the recent Standards Committee. Dr. Rupert has led numerous teams, hosted CCNE evaluations, presented at trainings and workshops, and you have a wealth of knowledge here between Drs. Hirsch and Rupert, real experts on CCNE accreditation and the standards dated 24. I want to remind folks that you do have the opportunity to ask questions. And what we have found in the first 3 webinars in our series, most people have been asking questions by typing questions in the chat. For those of you who may not yet be viewing the chat, I strongly recommend that you open up the chat function, because there have been dozens and dozens of fabulous questions asked by your peers, which we are getting answers to in real time in the chat function. And so please be monitoring that as you're listening to the presentation. I think you'll learn a lot. And to the extent possible, we will address oral questions or select questions from the chat to answer orally, time permitting, at the end of today's webinar. So please think about your questions related to Standard 3 and be ready to ask those via the chat. Okay, so we want this to be interactive. I know it will be. People have a lot of questions about Standard 3. We're happy to provide that information to you. So let's get started. The next slide, I just want to give you an important update, which is that CCNE is, in addition to this webinar series, which concludes today, and by the way, this archived webinar will be made available by the end of this week. So for anyone who wasn't able to join live, they will have access to that within a day or two. But we have a new initiative called Accreditation Connection. And you can see where that information is located on our website here on this slide. This is a great opportunity for all of our constituents who are interested in learning more about any aspect of CCNE to join us for a community meetup. You basically go to CCNE Accreditation Connection on our website shown here, and you can browse the topics that CCNE will be leading a discussion about for our community of interest throughout the year 2025. This is a new initiative. All you have to do is click and join and sign up for things that interest you, like how to submit a substantive change, how to apply for CCNE accreditation. We're going to be offering one that focuses more on faculty qualifications in the new year. So look at those and please join us in the new year for these exciting sessions with staff. And next, I just want to also share with the audience that we have updated the CCNE self-study template to the 2024 standards that are being discussed here. You will find the updated self-study template at this location on the PowerPoint on the CCNE website. There's also an updated program information form. There is a next slide. We are in the process of finalizing the template for those of you submitting continuous improvement progress reports in 2025. Those would be due either June 1st or December 1st of 2025, addressing the 2024 standards. That template will be posted at this location probably in a week. So check back for that before the end of the year and you'll find the template posted here. Okay, let's get into Standard 3. Dr. Hirsch, will you get us started?
Yes, thank you. Thank you, Jennifer. That's all exciting accomplishments. We're definitely moving ahead with the revised standards. Standard 3 happens to be my particular personal favorite. It has to do with program quality, curriculum, and teaching learning practices. And as you prepare to address Standard 3, just keep in mind that there's really 3 components to it. It provides you the opportunity to tell the story of your curriculum. And you might want to consider, how does the curriculum reflect the professional nursing standards and guidelines? How does the curriculum reflect the needs and expectations of the community of interest? And what are the teaching learning practices in varied environments that foster achievement of the expected student outcomes? Next slide. So programs must, this is just an overview of the substantive changes. So programs must demonstrate how the DCCs, that's the domains for nursing, the concepts for nursing practice, and the competencies. Those are delineated here at the top of the slide. This is what's required from the new AACN Revised Essentials. This can be done by a curriculum map, by aligning student learning outcomes with the DCCs and the other standards within syllabi, tables, spreadsheets, student assignments, and, as I said, course syllabi. Now that CCNE will accredit DNP programs with a nurse educator focus, the program must provide the graduate core, the 3 Ps, though not necessarily as 3 separate courses. The program must provide advanced disciplinary nursing knowledge beyond teaching learning content. That's specific for the nurse educator programs. For DNP, direct entry tracks for pre-licensure students, programs must provide advanced disciplinary knowledge and clinical experiences beyond the BSN level. So what does that mean? Courses and clinical that provide knowledge and experiences that deepen and broaden clinical knowledge in a substantive way. This advanced disciplinary knowledge is in addition to the teaching learning on content. Other components of the AACN 2021 Essentials not required include spheres of care, subcompetencies. No problem for them to be used as guidance, but again, they are not required. So next slide. More substantive changes to Standard 3. That I'm not going to read these, but regarding the first and third bullets on this slide, note that this content is not new, but CCNE wanted to split these concepts into distinct key elements for emphasis. We believe they're important and deserve special attention as separate and distinct key elements. Also, in this substantive change, clarification is provided in the respective elaboration statements. So next slide. Other substantive changes to Standard 3, we had additional clarifications for key element 3H, and we spoke to, for clarification, the specified minimum number of practice hours for DNP, for students in DNP programs. So the AACN Doctoral Essentials from 2006 required 1,000 hours. So this is not new, as 1,000 hours has always been required for DNP programs. Not necessarily direct care, but 1,000 hours. So different professional nursing standards and guidelines may have different or additional hour requirements that are not identified in the CCNE standards. So CCNE will not be reinforcing. Those programs could get cited if it claims to incorporate a specific requirement or set of standards established by another organization and then does not follow through. The onus is on the program to demonstrate to CCNE and the team or the decision makers that it is in compliance. Next slide. So here's some examples of supporting documentation. We really tried to clarify what would be helpful to programs to provide for the on-site evaluators. There's some examples of course content, of course incorporating the 10 domains, 8 concepts, and 45 competencies, and more examples of assignments reflecting incorporation, and evidence that graduate level content related to the APR and core is included, and then examples of didactic simulation and or clinical practice experiences that prepare students to provide care for diverse individuals and populations with diverse life experiences, perspectives, and backgrounds. Next slide. Start with key element 3A. Again, I'm not going to read through the slides, but I'll just point out some highlights. The program should provide clear statements of student outcomes for each of the programs under review. So ask yourself, how are the expected student outcomes congruent with the missions, goals, roles for which students are being prepared, and the expressed needs of the community of interest? So keep in mind that CCNE accredits programs, not tracks, so you will want to provide outcomes for each program under review. Key element 3A is an excellent opportunity to consider presenting a brief narrative for each program under review that provides the expected student outcomes, maybe using a table that offers visual congruence of the mission and goals with expected student outcomes. And depending on the number of programs under review, you might place the table directly in the narrative or in the appendix if it's lengthy. The evaluation team appreciates this level of analysis and synthesis and that has been conducted by the program. And further, you might want to highlight and or present an excerpt of minutes from a meeting that was held with your identified community of interest, in which you discuss express needs and expectations and what action was taken in response to those identified suggestions from the community of interest. Then more detailed evidence can be provided in supporting documentation in the resource room for review by the team. But I always really appreciate excerpts from minutes that really document when decisions were made. Okay, next slide. 3B, key element 3B. For this one, the program only has to do with baccalaureate curricula. The program only needs to address the key element 3B, 3C, 3D, and 3E for the degree and certificate under review. You will want to address how you developed, implemented, and revised the baccalaureate curricula to reflect the professional nursing standards and guidelines that are reflected in the curriculum and within the expected student outcomes, both individual and aggregate. Further, if you have adopted other professional nursing standards and guidelines, you will want to discuss how the curriculum addresses those as well. In some instances, the program has chosen to adopt specific guidelines, such as the Code of Ethics for nurses, nursing scope and standards, and the quality and safety education for nursing or QSIN competencies. In other instances, a program may decide to use other guidelines and standards more broadly to inform the development and revision of the baccalaureate curricula. Regardless, you will want to address each one appropriately. It's helpful in the self-study to discuss where and how content, knowledge, and skills are acquired by identified sets of standards and where they are incorporated in the curriculum. For example, select examples integrated into the narrative of the self-study are very useful to the team, the Accreditation Review Committee, and the Board of Commissioners during the review process for the program. Then greater detail can be presented in an appendix and in the resource room. For example, course syllabi should be organized by program and labeled and provided as supporting documentation in the resource room. Next slide, please. Key element 3C has to do with master's curriculum. Master's curricula are implemented and revised the same as the baccalaureate program to reflect those relevant professional nursing standards and guidelines, and they should be clearly evident throughout the curriculum. As we already discussed, additional standards and guidelines, such as those that prepare students for advanced certifications, may be appropriate to your program. It is required that master's degree APRN programs, clinical nurse specialist, nurse anesthesia, nurse midwife, and nurse practitioner incorporate separate comprehensive graduate level courses to address the APRN core, defined as the 3 Ps, which is advanced physiology, pathophysiology across the lifespan, advanced health assessment of all human systems, techniques, concepts, and approaches, advanced pharmacology, which includes pharmacodynamics, pharmacokinetics, and pharmacotherapeutics of all categories of agents, and additional APRN core that is specific to that particular role and population must be integrated as appropriate. If you offer a master's degree that has a direct care focus, such as a clinical nurse leader and or nurse educator, but are not APRN programs, you are required to include graduate level content addressing that APRN core, However, it is not required that that content be provided in separate courses. For example, a program may opt to provide an overview of the program of study, identify the key content and how it is addressed in the curriculum in the self-study, and then provide more detail in supporting documentation in the form of course syllabi provided in the resource room. Next slide, please. Key element 3C continued. This just delineates that the master's program incorporates the required components of the AACN 2021 Essentials. The program should address how they developed, implemented, and revised that master's curriculum to reflect these professional nursing standards and guidelines or components thereof, which are reflected in the curricula for the track and the program. Demonstrate where and how the content, knowledge, and skills derived from these professional nursing standards and guidelines are incorporated, and then look for provide evidence for where and how it incorporates the required components of the 2021 Essentials. Okay, next slide, please. The program must include content and practice experiences to attain disciplinary expertise in an advanced nursing practice specialty. For example, nurse educator track provides advanced disciplinary knowledge and experiences in addition to teaching learning content. An additional APR and core content specific to the role and population must be integrated throughout didactic and clinical courses. Now, Susan, I'm going to pause here for a moment. Is there something that you would like to add to key element 3C?
Yes, I'd like to talk a little bit more about that initial statement that you see on this slide. The master's degree program, regardless of focus, includes content and practice experiences to attain disciplinary experience in advanced nursing practice specialty.
And Susan, I'm just going to clarify for the archived recording, we're on slide 15, and this is key element 3C, the fourth paragraph of the elaboration for 3C. Please go on.
So there are master's degree programs, whether at an entry level or post-licensure, that have a generalist focus for some programs. And CCNE does not prohibit generalist tracks, nor does CCNE prescribe how tracks need to be titled. So in key element 3C, it's not CCNE's intention to suggest that master's generalist tracks must identify an advanced nursing specialty or prepare students for a particular advanced nursing specialty upon completion of the program. However, all master's degree programs, regardless of focus, whether they are generalist tracks or not, are expected to demonstrate that the curriculum includes graduate level content and practice experiences so that students attain disciplinary expertise in an advanced nursing practice specialty. But that does not mean that a generalist is preparing students as experts in any particular specialty. They can, if the program so chooses, or it can be just at a generalist specialty. And so this is supported in the statement in 3F that you'll see later on about graduate entry programs in nursing, incorporating generalist knowledge that are common to baccalaureate nursing education, as well as to advanced nursing knowledge. This is not a new CCNE expectation. It's congruent with both the old AACN essential documents as well as the new 2021 AACN essential document. So I'll let you go on from there, Anne.
Thank you, Susan. Appreciate that clarification. So let's advance to slide 16. Continuation of key element 3C. We've talked about this before, Master's degree programs that have a track with a direct career focus does not prepare APRNs, incorporate graduate level content. These are not required to be 3 separate courses. Next slide, please. Right, for the DMP programs, again, it is required to provide evidence of where and how content, knowledge, and skills required by identified sets of standards are incorporated into the curricula. So in key element 1B, programs are asked to identify what standards and guidelines, in addition to the required AACN 2021 essentials, they have incorporated into their curriculum. So in standard 3, specifically key elements 3C, D, E, and F, the programs then identify where and how and provide that evidence of the content, knowledge, and skills that are part of those standards they identified in key element 1B. DMP and APRN programs that have APRN programs must have the 3 Ps as 3 separate courses, and that is not required for postmasters DMP who hold current national certification as advanced practice nurses unless a program deems it necessary. Typically, the program provides documentation, transcripts, checklists, etc., that provide evidence that students completed that coursework in the 3 Ps, and that addresses the requirement. Next slide, please. This is more just elaboration of key element 3D. It's pretty much the same as the other programs, the 10 domains for nursing, the 8 concepts for nursing practice, and the 45 competencies. Next slide. This is also elaboration for the DMP programs that regardless of focus, it must include content and practice experiences to attain disciplinary expertise in advanced nursing practice. Next slide. Separate courses in the 3 Ps for APRN programs and for DMP tracks with the direct care focus that do not prepare APRNs. The incorporation of graduate level knowledge is important, addressing the APRN core, but it does not require 3 separate courses. Next slide. And this has to do, we've moved now into key element 3E, where we're talking about postgraduate certificate programs. The key elements are similar in that the program must clearly demonstrate where and how content, knowledge, and skills identified by the sets of standards are incorporated into the curriculum. The same guidance with the 3 Ps as 3 separate courses, but it is not required for students who have already completed such courses. Next slide. This is just more of the same for key element 3E, having to do with postgraduate certificate programs. And next slide, 20. Again, clarification of APRN tracks and what the APRN core is defined. Additional APRN core content specific to the role and population is also integrated throughout. And then separate courses for the 3 Ps are not required for certificate students who've already completed that. Next slide. Key element 3F. The curriculum is logically structured and sequenced to achieve the expected student outcomes. And then it delineates each program. Baccalaureate curricula build on a foundation of arts, sciences, and humanities. Master's curricula build on foundation comparable to baccalaureate level nursing knowledge. GMP curricula build on either master's and or baccalaureate foundation, depending on the level of entry. And then postgraduate builds on the graduate level nursing foundation. Next slide. Graduate programs are clearly based on a foundation comparable to baccalaureate degree in nursing. So how do programs provide evidence that this foundation is here? It's often a narrative. There may be an opportunity to use tables and show how different content is situated throughout the curricula. But it's the story that the program needs to tell about how this foundation is there. And then I am going to turn it over to Susan.
Thank you, Anne. So we'll move into key element 3G. The 2024 standards do separate out teaching learning practices from the preparation of students to provide care to diverse individuals and populations. So you'll now see each of these addressed across two different key elements. Key element 3G is going to address the teaching learning practices, and key element 4I that we'll talk about talks about care to diverse individuals and populations. So teaching learning practices include multiple modalities that the program may be using, including didactic courses, clinical, flipped classrooms, case studies, so a variety of modalities that might be utilized in different environments. And that includes classroom type environments as well as virtual environments, distance education, laboratory, and clinical. So the teaching learning practices, the program needs to demonstrate that they're appropriate to what they have identified as their student population. So that may include adult learners. Some programs do have students that are second language students, and then students that are in a postgraduate APRN certificate program may have differing needs than those that are in a degree program. And so examples of the teaching learning practices and how they relate to the community of interest that the program has identified are going to be important to include in the self-study. Next slide. (3H). This is really speaking to the planned clinical experiences. And so again, examples are going to be very important for the program to demonstrate how the planned clinical experiences are enabling their students to integrate new knowledge and attainment of the outcomes at the level of the program or the certificate, and that they are evaluated by faculty. So certainly preceptors or mentors can be providing input into the evaluation, but the ultimate responsibility for evaluation of these clinical practice experiences falls to the faculty. What is very important to note here is that clinical practice experiences are provided for students in all programs, and that also includes distance education offerings. So the clinical experiences need to align with the student and the program outcomes that have been identified, and the experiences need to be planned, implemented, and evaluated. And you'll notice here in the last part of the evaluation, it speaks to direct care focus. So this includes, but it's not limited to post-licensure baccalaureate tracks like an RN to BSN track or nurse educator tracks. So all tracks, regardless in programs, need to provide direct care experiences. And that's defined as care that's provided to individuals, families, groups, and or communities, and they are designed to advance the knowledge and the expertise of students in a clinical area of practice. Next slide. So Anne mentioned this a little earlier in terms of the number of hours of clinical that are required in programs. So DNP programs require a minimum of 1,000 hours of practice post-baccalaureate as part of a supervised academic program. And what that means in terms of supervised academic program is, this question comes up often, can we use work experiences that the student has had in the past or they're currently having? In order to count within the academic program, they need to be supervised. So faculty supervised experiences. Programs that prepare students for a nurse practitioner certification provide a minimum of 500 direct care hours. So if that nurse practitioner track is within a DNP program, those 500 hours are included in that minimum of 1,000 practice hours. And we know that there are programs out there that have more than 500 direct care hours. That's fine. The minimum is 500, as the certification bodies currently have a requirement for 500 direct care. If that changes at some point in the future and those hours are increased for nurse practitioner certification, then programs will be held to increasing the number so that students will be eligible for those certification exams.
Susan,
Yes.
there are a number of questions in the chat about hours, and I want to stay on this slide, which is slide 28, just for a moment, because there are a couple questions just clarifying hours. And as Anne presented earlier, the minimum 1,000 hours post-baccalaureate DNP is not a new requirement. That was in the old AACN doctoral essentials. It has been a CCNE requirement for many years, and that is not in question here. One of our constituents has asked, does the 500-hour requirement apply to programs that are MSN, but not nurse practitioner? Can you address that?
Yes, the 500 direct care is specific to nurse practitioner tracks, whether they are in a master's program or in a DNP program. If it is a master's track that is a non-advanced practice track, for example, nurse educator, nurse leader, then those 500 hours do not apply. However, the program does need to demonstrate that they are providing clinical hours and direct care if it is a direct care role, such as nurse educator.
There's another question. If the master's program does not offer NP tracks, is there a set number of clinical hours?
CCNE does not prescribe a set number of hours if it is not a nurse practitioner track. However, again, they do need to demonstrate that there are clinical hour experiences for the students that are appropriate to preparing them for this specific role.
Great, thank you. So one of the other questions that we sometimes get is, are nursing administration and nurse educator programs also required to do 500 hours? And the answer is no, CCNE does not require that. Do be mindful, though, if your program is preparing individuals to sit for a particular certification exam, it is the program's responsibility to know how many hours are required for your students to be eligible to sit for that exam, even if it's not a nurse practitioner program. Thanks, Susan. Let's keep moving.
So let's talk a little bit about direct care, because this question comes up very often in terms of what is meant by direct care and that requirement for direct care clinical hours for tracks that are preparing individuals for a direct care role. So direct care, as I mentioned earlier, refers to care that's provided to individuals, families, groups, and/or communities designed to advance the knowledge and the expertise of students in a clinical area of practice. So let's go on to the next slide. and talk about some of those planned experiences. So key element 3I was one that was split out, as I mentioned earlier, so that it really speaks to providing care to diverse individuals and populations. So the program needs to demonstrate that it provides planned didactic, simulation, and or clinical experiences that prepare students to provide care to diverse individuals and populations. So this can be done in a variety of settings, appropriate to whatever role the student is being prepared to, so that they are prepared to provide that care to individuals and populations. So let's go on to the next slide. The curriculum includes planned experience that foster interprofessional collaborative practice. So this key element is a little expanded from the current standards that are in effect until the end of this month. In the past, the interprofessional collaborative practice was really addressed in terms of clinical experiences. In this key element, the program can provide interprofessional collaborative practice experiences to students in a variety of ways. It can be done through planned didactic, it can be done through simulation experiences and or clinical practice experiences so that students are prepared for interprofessional collaborative practice. So the program can provide examples of how they are providing those opportunities to students so that they have the opportunity to collaborate with a variety of individuals and or organizations so that they are able to demonstrate and develop necessary communication skills to enhance their patient outcomes. So let's go on to the next slide. So let's go back and talk again about clinical practice experiences in some of the different programs. So the question often comes up, what types of direct care clinical experiences might be appropriate for students in an RN to BSN track within a baccalaureate program? And regardless of if this is a generic baccalaureate program or an RN to BSN track in a baccalaureate program, all students need to have clinical experiences that include direct care. So some examples of direct care that might be utilized in an RN to BSN track that we've seen is working with patients in pain management or in a particular specialty area. It might be working on policies, changes within a system, beyond just an academic kind of experience of preparing the policy, but also working on how is that policy going to be implemented. It could be done in community health experiences with blood pressure, diabetic screening, skills that would be preparing someone in an RN to BSN track beyond the preparation that they had within their basic RN education. Windshield surveys, we see this pretty commonly given as an example. Windshield surveys are when students are generally driving through communities, identifying resources within the communities that address the needs of that population. Driving through a community itself and identifying things is not a direct care experience. It is a valuable experience. It would be considered to be indirect care, but something needs to be done with that information or data that the students are collecting in the windshield survey. So they need to take that information, and in order for it to become a direct care experience, plan and implement activities that are going to improve the needs of that population. Assessment in a community setting, again, the assessment piece of it, if it stops there, that's really an indirect experience. but using that assessment then to design and implement education or some type of program to improve the health outcomes, then those experiences become direct care. So I think the bottom line here is, gathering information or gathering data is an indirect activity, but what the students do with that information in terms of planning, implementing, and evaluating things for the community of interest or the population, that is what moves it to a direct care clinical experience. So let's go on to the next slide. So these are some examples of what would not be considered to be direct care. Just presenting a poster in a public setting would not be direct care. Again, it would be considered to be indirect care. It's a valuable clinical experience that students can have. But in order for it to go to a direct care level, something else needs to be done with that information. Just practicing skills in a lab or simulation is not direct care. And again, I already mentioned the windshield survey, a valuable experience for students, but they need to use that information to improve the population's health in order for it to be a direct care experience. Next slide. So let's talk about it at a graduate level. Direct care examples that might be utilized at a graduate level are experiences that are going to contribute to the development of advanced nursing skills or advanced nursing knowledge. It could be in a very specific specialty, but it doesn't have to be. So things like critical care, wound care, palliative care, specialized areas. Participating in community outreach activities, for example, care given within a mobile health clinic. Preparing patient education for patients or families based on advanced knowledge in a specialty discipline. And implementing a community-based project. Again, you'll see the words implementation, evaluation. Those are the aspects that really elevate it to a direct care experience. Next slide. Experiences that are not direct care. Again, valuable experiences, but not direct care. 100% simulation. So that would include both virtual simulations as well as standardized patient experiences, teaching students or working with faculty who supervise students, participating in staff development activities, or didactic content that the student has in APRN core courses, the 3P courses, such as assessing case studies. Next slide. So nurse educator tracks program might have them at either the master's degree level or the DNP degree level. This question comes up again very commonly. What should the focus of the practice experiences be for students that are in a nurse educator track? Oftentimes, they are going to have clinical experiences that relate to the development of the role of an educator. That can be in terms of working with students. It can be in staff development types of activities. Those are important clinical experiences in preparing for the role. However, students in nurse educator tracks, in addition, need to have direct care clinical experiences that are going to expand their knowledge and skill level in an advanced nursing practice role. Doesn't mean that they're becoming nurse practitioners or clinical nurse specialists, but they need to advance their knowledge and skill in nursing in a particular area. Otherwise, without those experiences, students are being prepared to educate with a baccalaureate level of knowledge. So they need to have experiences that are really going to give them that in-depth preparation so that they're able to teach in a particular area of nursing. Next slide. So again, those experiences for nurse educators for direct care experiences can be in a particular area of clinical nursing practice. It does need to be at an elevated level of nursing practice so that they're able to develop that knowledge and skill to teach beyond their entry-level preparation. Next slide. I do want to note for programs that are using distance education, that is part of the documentation that's presented in the self-study or in the virtual resource room. The program does need to provide evidence that the institution or the program has processes in place that protect the student privacy and that students are notified of any projected additional student charges that are going to be associated with verifying their identity at the time of enrollment. And Jennifer, do you want to expand on that a little bit?
Well, I think that this really links nicely to CCNE's truth in advertising expectations in an earlier standard about the program being forthcoming when it comes to the fees, tuition, costs related to being part of the program and being a student at your institution. And, you know, we know that all institutions are concerned about, you know, student privacy and for also faculty knowing that the student who is in the room is actually the student enrolled. And so if there are policies around that and additional fees, the program should be transparent to the students about that. So that's really a best practice in higher education that we thought we would emphasize here.
Okay, so let's move on to key element 3K. This has to do with student performance being evaluated by faculty, reflecting achievement of the expected student outcomes. And the program needs to demonstrate that it has evaluation policies and procedures for student performance and evaluation. So this would include examples of grading criteria for courses that are communicated to students. That communication might be in a syllabus. It can be on a website. So in a variety of ways. So speaking to the examples and providing evidence of that is going to be important within the self-study. Next slide. 3L, the curriculum and teaching learning practices are evaluated at regularly scheduled intervals, and the data are used to foster ongoing improvement. This is not a key element. So the program needs to provide, again, examples and evidence of how the teaching learning practices are being evaluated. So for example, it might be an end of course evaluation. It may be a faculty evaluation. It may be done both quantitatively and or qualitatively. That really is up to the program to decide how they want to evaluate the curriculum. And then a very important piece of this key element that you'll see in the elaboration is not only are the data collected, but how are they used to improve the teaching learning practices? How are those data being used to inform those decisions that facilitate the achievement of student outcomes? I know that Standard 4 talks about program outcomes and the use of data of program outcomes. This key element is a little bit different than that. It's not looking at the overall program outcomes and the overall use of the data. It's very specific to the curriculum and the teaching learning practices. So these data may be a part of the program outcomes, but they're very specific to the curriculum and the teaching learning practices. So it is different than the data that is being requested in Standard 4. And Anne, do you want to comment on that at all as well? I think you're on mute.
Yeah, I'm sorry, Susan, couldn't find my mute button. Unmute button. No, I think that's how I would explain it.
Okay, let's go on to the supporting documentation. And I think, Jennifer, you were going to highlight some of the changes. And you're on mute.
Thank you. Just want to remind folks that a lot of great questions have been typed in the chat and are being answered in real time. So we will respond to these questions that we think are most relevant to most people. And before we go there, and please continue to type in your questions, I just want to emphasize that at the end of each standard, and Standard 3 is no different, there is a published list of supporting documentation items. And for Standard 3, this list is 15 items long. And each of these items is related to one or more of the key elements within Standard 3. And I want to emphasize that, that the 15 items listed as supporting documentation can be made available in the self-study document. It could be made in the virtual resource room, which we call the electronic resources that support the on-site evaluation. It could be included in the appendix. So there are multiple ways that this information can be provided to CCNE. We're not prescriptive in terms of the ways in which these items are provided, but they are required areas of evidence. There might be reasonable alternatives that exist for your program when providing something. For example, your program may not provide minutes, but it might have other formal records of decision-making that has occurred. As I look at these first 5 on slide 41, the 2 that I want to highlight as being updated since the prior edition of the standards include numbers 3 and numbers 4, because of course, as you have heard multiple times in today's webinar, CCNE is requiring the 3 major components of the AACN Essentials titled as the domains for nursing, the concepts for nursing practice, and the competencies. And so just to emphasize that we do expect programs to be prepared to provide examples of course content and or assignments that reflect the incorporation of these 3 components of the essentials. And I think, as Susan and Anne have also stated very clearly, programs are welcome to use many other components of the AACN 2021 Essentials. For example, your program may choose to use the spheres of care, various subcompetencies, or all of the subcompetencies. There is an opportunity and great resources available to programs on the AACN website and in various programming that has been offered by AACN to learn more about the essentials in its entirety, and toolkits and ways that you can refer and use those essentials as guidelines. Number 4 is also something that we want to emphasize, because programs are required to select additional professional nursing standards and guidelines or sections thereof, components thereof, that are relevant and current to your program offerings. And so, as Anne mentioned earlier, if your program identified in key element 1B, like Bravo, that you are using the NTF, the National Task Force standards for evaluation of NP programs, you would be expected to provide evidence that your program has incorporated the NTF standards dated 2022. Another example is that your program may select that it uses CUSIN or the ANA Code of Ethics or your state board of nursing rules and regulations and has incorporated those. Those are all considered additional professional nursing standards and guidelines beyond what CCNE requires, which is, of course, the domains, concepts, and competencies from the 2021 AACN Essentials. So be aware of those two items in the list. And if we go to the next set of requirements, I'd like to emphasize number 6 here in the list of 15. We are looking for evidence that graduate level content related to the APRN core is included in master's degree programs that have direct care tracks, such as nurse educator and clinical nurse leader, and DNP programs that have direct care track, like nurse educator. So that is also clarified in this edition of the document. Number 10 is also worth highlighting, that we do want the program to be prepared to provide examples of didactic, simulation, and/or clinical practice experiences that prepare students to provide care, rather, to individuals and populations with diverse life experiences, perspectives, and backgrounds. And I think our presenter already addressed that that could be through didactic coursework, it could be through simulation and/or practice experiences that are afforded to your students. We pulled that out separately in the standards. We do think that it's important and wanted to make that stand out in the 2024 standards. In the next slide, you'll see items 11 through 15. I think they're pretty self-explanatory. We are looking for examples of things, documentation that faculty are responsible for grading all courses and clinical experiences. And again, think about what is relevant to your program offerings and which examples would demonstrate that you are complying with the key elements here within Standard 3. So let's get into the questions. We've got some fabulous questions. I want to start with simulation because there are a number of questions about that. So there were some questions, and of course, our wonderful Associate Director, Priya Lorenzen, has already been addressing these in the chat. But there was a question about whether simulation is required or whether there's a minimum or a maximum or a percentage that can be used. And the answer, in a nutshell, is that simulation is not required, nor do we provide a minimum or a percentage. However, a program cannot only offer simulated experiences. There has to be some direct care experiences that is not done by simulation. And again, that is not a new requirement. That has been in the former AACN Essentials. You might recall that term augment. Simulation is intended to augment, not replace direct care clinical. Any comments about simulation by our presenters?
Jennifer, I'll just talk to it from nurse practitioner education, and this is also not new. Simulation experiences can count in clinical hours beyond the 500 direct care, but there must be a minimum of 500 direct care.
Mm-hmm.
Any hours above that can be direct care and/or simulation.
Yeah, Jennifer, I'll just add too.
Thank you.
Okay. We have not emphasized yet. One of the values of CCNE is innovation and creativity, and that's something that simulation can certainly add to. So we would not want to either require the use of, but as Susan said, it can't be part of that direct care that is required for certification for an APRN. But love to see those opportunities for students to learn in new ways, and simulation is certainly one of those.
Great, thank you. And it's also been pointed out in the chat that programs should be sure to look at your state board requirements, which certainly may have percentage limitations or upper limit hours on simulation. So be sure to be aware of that. Obviously, CCNE is not going to put in place any requirements here that will conflict with your state board requirements. So, but you do need to meet both your state board requirements as well as the CCNE requirements. So CCNE may not have a limit, but if your state board does, you need to follow the state board rule, which is also not breaking the CCNE rule, if that makes sense. There also, let's see. There are a number of questions about aspects of the essentials of AACN dated 2021 that I think we've now clarified. They are not CCNE requirements, such as there are level 1 and level 2 expectations in the AACN essentials. You will see that nowhere in the CCNE accreditation standards is level 1 and level 2 mentioned. There are spheres of care and subcompetencies, again, not required by CCNE. And someone also picked up on the 500-hour requirement in the essentials that applies to tracks that are not preparing APRNs, such as administration, leadership, educator. And again, that is not a CCNE requirement. And so that is not part of the domains, concepts, and competencies that are required through the CCNE accreditation standards. Obviously, anybody who is using the essentials as a guideline and has questions and would like interpretation by AACN on the essentials should be contacting the AACN staff to get their questions answered about the essentials language. If you have a question about CCNE's accreditation standards and key elements and our interpretation of what CCNE requires, of course, please ask your questions here. And also, you know that you have great access to our wonderful staff team to get those questions answered. Okay, so somebody has asked the question about the 45 competencies and whether those apply to all programs or only certain programs. Her specific question is, are all 45 competencies required for non-clinical master's programs, such as those with educator or administration focus? Who wants to answer that first? Susan, are you on mute?
Oh, I thought Anne wanted to answer that.
Oh,
so
go ahead, Anne.
she addressed that in
Very
her key
good.
It is up to the programs to show how all of those competencies are in some way incorporated into the curriculum. Now, some programs, depending on their focus or specialty, if you will have more of an emphasis on certain competencies versus others. but they are not new to nursing. We've been focusing on those competencies for quite some time. So yes, there has to be incorporation of the 45 competencies, not the sub-competencies.
Very good. There's a question about whether a program can choose as the additional professional nursing standards and guidelines that it selects or components thereof, whether a program could choose the spheres of care as those additional components that it is choosing to incorporate and provide evidence of that. And the answer is absolutely yes. And the same is true for sub-competencies. A program may select some or all sub-competencies as the program deems them relevant for your program offerings. And you would then provide evidence of incorporation of those that are current and relevant to your program offerings that you have selected beyond what CCNE requires, which is, of course, the domains, concepts, and competencies. Any other thoughts there on our from our presenters about that?
No,
I agree with you.
Stress
Go
that,
ahead, Susan.
Jennifer. I think the one important thing to stress though is whatever the program identifies in standard 1 as those additional standards or components of, there is that linkage in standard 3. So whatever is identified in standard 1 as those components need to be addressed in standard 3. The other thing I would say for programs to be mindful as they are looking at components or entire documents are they're going to be held to whatever they've identified. So for example, if a program identifies that they are utilizing the entirety of the 2021 AACN Essentials, then they would be held to the spheres of care, all of the subcompetencies, that 500 hour. The same thing with the National Task Force standards. If the entire document is identified as being utilized, it has some differences in terms of requirements for clinical hours, and the program would be held to that if they select the entire document.
That's right. And someone has asked, am I correct that additional professional nursing standards and guidelines or components thereof, in addition to the domains, concepts, and competencies from the essentials, must be incorporated, and such that a program may not only use the domains, concepts, and competencies? And the answer to that is yes, you are correct. Something additionally must be chosen by the program, and whatever is chosen must be relevant and current to your program offering. So excellent questions there. There are a few questions about the 3 Ps, the beloved APRN core. And I'm wondering if our presenters could just clarify again, this is not a new concept. This has been required by CCNE for many years and is consistent with both the old essentials and the new essentials. But can you clarify which programs must require 3 separate graduate level courses for the APRN core, or the 3 Ps as we call it? And then which programs have to have content related to the APRN core, but not necessarily 3 separate courses? Can you address that?
APRN tracks, which would include nurse practitioner, clinical nurse specialist, nurse anesthetist. The APRN roles do require that the 3 Ps be presented as separate courses. For other tracks that have a direct care focus, like nurse educator, they do need to include in the curriculum the 3 P content. That can be done as 3 separate courses, or it could be done as an integrated course. That really is the decision of the program to make. I know sometimes we have a question, what's the better way to do it? And that really is the decision of the program. Some programs do choose to do it as 3 separate courses because students oftentimes do come back into postgraduate programs, and rather than have the students repeat that content, they give it as 3 separate courses, but CCNE does not prescribe that.
Thank you. Anything to add there, Anne?
No, I'm just in awe of the wonderful questions and the responsiveness of the staff to some of the questions in the chat. And one has to do with nurse educators as a direct care role. And I have to say, we spent quite a bit of time on how to ensure that we were doing justice to our constituents who offer nurse educator tracks and provide meaningful accreditation of those tracks. So nurse educators are considered a direct care role, and that requires not only the 3 Ps in one course, or 3 if you choose, but it can be in one course, but also clinical practice hours that are direct care. And I've seen some questions in the chat about that. There are ways to do that can be quite meaningful. That doesn't mean that they have to move into an APRN role or an APRN preceptor to work with. You could work with a diabetic nurse educator or a wound care nurse. Anything that elevates the care that the nurse educator will be able to then convey and nurture their students to also be able to do. So I just want to clarify that nurse educator is a direct care role.
Yes. And again, that's not new. That's been the case since the 2011 Master's Essentials were issued by AACN. But it's good to certainly reinforce that continuing expectation. And there were some questions in the chat, but the questions came in before Susan presented the very clear examples of what constitutes direct care and what is not considered to be direct care, but may still be very valuable for a nurse educator track. So we encourage people to go back and review those PowerPoints and examples that were provided about clinical experiences. Someone has asked if there are any sort of best practices that our presenters are seeing or hearing about, and what CCNE is anticipating in terms of how programs will go about demonstrating incorporation of the 10 domains, the 8 competencies, and the 10 domains, the 8 concepts, and the 45 competencies. You know, a lot of people think of this as a curricular map. The concepts are a little different from the domains and the competencies, and all of the competencies fall under domains. So, you know, programs, as Anne said, can be creative in how this is put to writing. We do anticipate that many programs will produce evidence, much like they've always done, showing incorporation of old essentials and where that course content is found, with examples of student assignments, outcomes, those types of things. Could you all say a few words about just some of the innovative ways that programs might be displaying or illustrating incorporation of the DCCs, domains, concepts, and competencies, coming up in 2025?
You know, I had my most recent experience was late November, early November. And so I did not have the opportunity to use the new template or see, but the program had already gone ahead in their excitement and looking towards the future, and done quite a bit with the incorporation of the DCCs. And of course, because of the volume of competencies, it requires spreadsheets and minds that work in that kind of way, but they've done a really good job in demonstrating which courses and how those required components of the 2021 AACN essentials were incorporated into the program. It wasn't done, but they weren't required to even have it. But it was impressive that they had moved ahead and were excited about it, felt that they were appropriate for their program. But they were in the 2018
Yep.
CCNEs, so they had to do that as well. But
we encourage programs to type in the chat if you have ideas or ways that your program is thinking about demonstrating incorporation of the domains, concepts, and competencies for CCNE. You're welcome to share with your colleagues in the chat. Susan, did you have any additional thoughts on that?
I don't think it's going to be a lot different than the way programs have been doing it all along with curriculum maps, with tables. Some are using different programs like Exact to demonstrate how they are mapping it throughout the curriculum. But I think it'll be pretty similar to the way that programs have always done it.
Great. Let's see. There was a question about preceptor requirements and requirements for faculty teaching clinical. But I'm gonna move on because we did present on that relative to our standard 2 webinar. So I do encourage you to look at the standard 2, listen to that webinar and look at the PowerPoints where you will find elaboration statements related to those key elements. Someone is asking relative to key element 3F, like Frank, for a postmaster's DNP leadership program. Could you please share strategies for demonstrating the curriculum builds on a master's degree? So this is a postmaster's DNP program with a leadership track and strategies for demonstrating the curriculum builds on a master's degree.
well,
Either of you want to go ahead, Anne?
yeah, I guess it would depend on the postmaster's students coming into the DNP APRN prepared. Is that a requirement for the program? And this is a leadership, so a non-direct role. It would just depend on what the focus of the program is, and then for the program to tell that story. Maybe start with a narrative and then have some tables if it clarifies what the coursework is. There are many programs like that across the nation that are moving master's prepared APRNs to a DNP level.
Right.
So the
And of course,
competencies most focused on are the leadership ones.
yeah, of course, it wouldn't have to be an APRN.
It wouldn't have to be.
We don't know yet if this program, what they require for admission. But of course, the answer would depend on that. Most often we see that there is a gap analysis to see who are the students coming in, what do they have, and where do they need to go in order to determine what those requirements are. Any other thoughts on that?
No, I think that the gap analysis is a great strategy because that way the program can address what competencies were met within the master's program and which ones need to be built on in the DNP portion of the postmaster's program.
Someone has asked if simulation is considered direct patient care.
And the answer to that is no.
And we did talk about simulation activities augmenting direct care clinical. Let's see. Couple questions about faculty. Do our presenters see anything in the chat that we feel we could address in the next minute or so? Oh, there is a good question about whether collected data from students should be de-identified. So whether collected student assignment evidence for CCNE should be de-identified. Anne and Susan, could you speak to that in terms of use of the virtual resource room and whether we would want student names to be shared?
You know, if it's a student assignment, yes, de-identify it. If it's a student poster that's already out there and part of the public domain, no, it would be fine to have the student name on that. Oftentimes, it's helpful to have minutes that have the students' names in them and identified as students so that we know that the student reps were there and who those student reps are. Anything else, Susan?
I'm thinking of data that we've seen, for example, like NCLEX scores or test scores, those should be de-identified.
Yeah, one of the things CCNE is concerned about is personally identifiable information. So PII, you should not be, any program should not submit to CCNE any materials that contains PII of students, faculty, or other members of your community of interest, such as social security numbers, student identifiers, driver's license numbers, birth dates. Those are some examples. So that is something to watch out for. We haven't seen that this has been a big problem, but we are mindful of the need for the program to secure that information and not be providing it in the self-study document or materials that are provided to CCNE and its volunteers. We don't want that information to be on the record to protect your constituents' privacy, of course. So, well, thank you very much. There were some wonderful questions here. We appreciate, of course, the staff answering the questions in the chat. I also appreciate the time and generosity of our two presenters to come, not just today, but come back again so many times to be part of a CCNE webinar or a forum or a training to help educate our other volunteers and program constituents, and really our stakeholders nationally in the understanding CCNE accreditation and the standards for accreditation. So thank you everyone for being part of today's webinar. This concludes the webinar series addressing the 2024 standards, and we hope everyone has a wonderful rest of your day. Bye-bye.